I want to thank the organizers, David and Heidi, and all the folks here for inviting me. This is a great opportunity. But David tricked me and said I get to come to North Carolina. It'll be sunny. I'll get to golf. Yesterday it was sunny and 70 in Chicago, and that's the plan for today. So you owe me. No, but I'm happy to be here. This is a big shift of gears from the last talk because we're not talking about HIV-infected folks so much. We're more talking about sort of the prevention side and people being at risk. And you know, I am a HIV clinician. I'm a researcher. I do clinical research in clinical trials in the AIDS Clinical Trials Group. But I have always had an interest in the Black community and sort of the disproportionate infections in the Black community and why that is, and in particular in Black women. And so this talk kind of focuses on my interest there and some of the work that I've done, as well as a little bit of work that other folks have done on this question of risk perception. So I'm going to start out and give you a little bit of statistics, much of which you already know, but it's mostly to set the context for what we're talking about. So we'll talk about a little bit about statistics of the disease in women. We'll talk about some of the drivers of the higher rates of HIV disease in Black women. We'll talk about what little data exists on perception of risk in women. And then we'll talk about whether or not it matters. And then we'll talk a little bit about how we could do better. So this is data that you all are very familiar with. So this shows you some of the CDC data focused on the HIV diagnosis in adults. But this is specifically focused on females. And so you can look at this, and basically the story is the same in that Blacks are way up here and every other group is way down here. I think the good news is that this number isn't doing this anymore, it's going down. However, the difference here is certainly still quite concerning. This just shows you that information more for the people who are numbers people, and you can just see the rates. And so if you really look at if you look at the rates among Black women, you can see the rates roughly 40 per 100,000 in comparison to whites, which is about 2 per 100,000, so a 20-fold difference in the rates of HIV infection. And then this just gives you an idea about what's going on around the country, and I think that folks down here are probably very familiar with the fact that the South is really catching up and almost caught up to the Northeast and has really gone past the Midwest when it comes to the cases among women. It certainly is, as I know you guys know, a really big challenge here in the South. And you also know that, that the rates relative to the population for African Americans are very, very dramatic. So you can see again on this side of the slide, diagnosis of HIV infection, and then the female population. So African American women make up about 12% of the population, but an overwhelming 64% of the cases of HIV in the country. In comparison, whites make up roughly 66% of the population and only 17% of HIV cases among women. And then just to talk about sort of how is it happening, when I talk to a lot of people sort of that aren't in the field, lots of folks think that women who contract HIV primarily from drug use or injection drug use in particular. And the reality is you all here in this room know very well that women contract HIV overwhelmingly from heterosexual contact. Now, that's not to say that drug use isn't a part of that, but not typically injection drug use. So we know that crack, cocaine use, and other drugs, as well as alcohol, play a role, but injection drug use is not the driver. This is just to give you a little bit more updated look at sort of risk of infection. This is data from the ISIS study, which was HPTN, or HIV Prevention Trials Network 064, and this basically looked at women in sort of high-risk communities, or in how they defined high-risk communities was areas where there was a high HIV prevalence. So I enrolled over 2,000 women from these areas. Most of them were Black. some Hispanic, and a few white. At baseline, when they walked through the door, 1.5% of these women were newly diagnosed with HIV. So when they entered the trial, they found out that they were HIV infected for the first time. So the 1.5%. Now, mind you, that's a huge, that number may not sound that big, but just think about 1.5% of the population. Overall, in the United States, the number is around 0.1% is the overall rate of HIV infection. So this is much, much higher than the general population. And you can see here that they looked at the acute infection at enrollment. They found 2 people who didn't test positive, but were actually in the point of becoming infected. So they were at a point of transitioning to being antibody positive. They were already acutely infected. And then when they followed people over time, there were 4 seroconversions when they watched women. That led to an estimation that was 5 times higher than the CDC 0.5% estimate for black women. And so this is just basically looking real time at some of the communities with the greatest amount of risk. And why do these communities have the greatest amount of risk? Well, there's a high prevalence in the communities. And what I want you to begin to kind of think about is that the risk for a lot of these women is not necessarily about their behavior, but about their environment. So I asked this question, why black women? Physical and emotional vulnerability, this question of biological vulnerability. Now, we know and have known for really decades that black women have disproportionate infections and disproportionate rates of STDs. And so we know that that creates some biological vulnerability. But when I say biological vulnerability, I don't mean that there's something different about black women that makes them at greater risk for contracting HIV biologically, like there's something different about black women's vaginas versus about white women's vaginas. And I can tell you that I have to make this point because I literally just a few days ago, I had a very extensive discussion with a young man whose research was looking at exactly that question. He was convinced that, don't laugh, this is serious. This is his research. I had to calm him down. His research was that black women have higher rates of bacterial vaginosis, and bacterial vaginosis, we know, is associated with increased risk of HIV transmission. And so his theory was that black women were more vulnerable to bacterial vaginosis than white women, and that's what the difference, that 20-fold difference in the rate of HIV, he thought was all that. I sent him this slide set and this list, just so that he can begin to see that even if you can find that there's maybe some tiny little biological differences, those differences, one, to associate them with race is problematic because we all know that race is really more of a social marker. Genetics is very different. So if you wanted to look for some genetic differences, you might be able to find that there are some. But to call it a race difference and that there's a different biology is, I think, stepping a little bit too far. But when I say biological vulnerability, I mean related to the prevalence of STDs. Violence against women is more common in women of color. It's more common in poor communities. Women of color are more likely to live in poor communities. Low self-esteem and dependence on men, common in communities where if you're poor, you're more likely, if you're a poor woman, you're more likely to be dependent on a man. And if you're dependent on a man, you have less power, less ability to resist sex, to make demands for use of condoms or for protecting yourself. Poverty brings all of that together. Again, dependence on men financially. And then sex as a commodity. So you engage with a particular individual because you can get access to things that you need or want because of interacting with that individual. Concurrency, some of this data is from our wonderful colleague, Ada Adamora, here at UNC. I'm not sure if Ada's here today, but Ada has done great work that has talked about concurrency. Now, concurrency, of course, you all know, is the real fancy term for saying chick on the side. But long and short of it, it just means that you're not just in a relationship with one person, but that person has relationships outside of the primary relationship. And that relationships outside may be with other men, it may be with women, but the main point is that it's other partners on the side and other individuals that you're exposed to. And some of the data on that is that the 5-year prevalence of concurrency was higher among blacks than the general population. Now, there's a lot of reasons why that is, and again, a lot of ADA's work goes into that, and I think incarceration is a big part of that, and poverty is a big part of that. If you talk, particularly if you talk about incarceration, you talk about there being a lot less available black men in comparison to black women, and so you're willing to compromise, black women being more willing to compromise and deal with someone even though that person may come a little extra baggage on them. They may know that they have a chick on the side, but he's really the only guy you can get, or he's the best guy, or he's good to you in some way, and so you keep him even though he carries some risk. Black women's marriage rates are 50% lower than other racial groups. Pregnancy desires and benefits, I think we have to kind of think about that for particularly a lot of younger women who in many ways are feeling a need for family or feeling a need for love and unconditional love that you can sometimes only get from having a child. And sometimes the way that our social system is set up, that is a way for women to get access to resources is to have a baby. So if you have a desire for pregnancy, then you're obviously not doing the things that you need to do in order to protect against HIV. Mental illness is a major challenge in our communities, and again, disproportionately in poor communities. Substance use, we talked about that, and then lack of access to both information and the healthcare gap. So why all of these things are a big part of what is driving HIV in communities of color. But again, understanding this, you have to recognize that this isn't necessarily about sexual behaviors, about something somebody did. It's about a community-based or an environmental risk. I like to talk about Precious. How many, now I don't have any audience response questions, but everybody, how many in the room saw the movie Precious? So the overwhelming majority of people in the room saw the movie Precious. And when I saw it, it was, you know, like you, I was shocked, and it grabbed me in a lot of ways, but here's the way I describe it, and this is not what you read on the back of the DVD. This is my description. My description is that this is a tragic story of the life experience of a poor young black woman that's intertwined with a not too subtle message of low health literacy, misconceptions about HIV risk, and competing priorities that contribute to excess HIV disease and excess mortality. There's a quote during the movie where she said, "They tell me I have HIV and I could die, but I can't worry about that because I got to take care of these kids." So black women are more vulnerable, and then when black women are infected, the priorities can sometimes be different, and priorities around everybody but themselves. So this concept of high-risk environment, with or without high-risk behavior. Here's a little bit of the background data that kind of just, I think, underscores the point. So there was a study a couple of years ago looking at youth. And black youth with low-risk behavior were 25 times more likely than white youth to acquire an STD. Now, low risk for these individuals was having low number of partners, low alcohol use, and low tobacco or drug use. So again, low-risk African Americans are more likely, 25 times more likely to acquire an STD than low-risk white individuals. This is some of ADA's data here in North Carolina looking at heterosexually acquired HIV among African American women in particular. This was a case control study, HIV positive compared to HIV negative African American women. 27% of the women in this cohort that were HIV infected had no high risk, quote unquote, high risk behavior. The risk factors for getting HIV in these low risk cases were less than high school education, food insecurity, and a non-monogamous sexual partner. So it wasn't about her behavior, it was about the environment that she was in, and in some cases her partner's behavior. The CDC is doing a national HIV behavioral surveillance study. This particular subset was looking at the DC population. Now we know DC has been really dramatically impacted, really has some of the highest rates in the country and rates comparable to some of the worst areas in the world. And so this particular survey looked at heterosexuals. There were 750 individuals who were surveyed. Most of them were African American. 60% of them had an annual income of less than $10,000 a year, so well below the federal poverty level. 5% of this population, 5% of this population was HIV infected. It was 63% of the women and 6.3% of the women and 3.9% of the men. Now, more than 50% of the individuals had a history of incarceration. So incarceration playing a huge role in this community risk. 46% of the women had one sexual partner in the last year. So the notion that women that acquire HIV have lots of partners and are quote unquote promiscuous is just not bared out by the facts. And there was another study that was published a couple of years ago that really looked at sexual behaviors in individuals in the country and found that condom use actually was higher among blacks and Hispanics than other populations. So no, the risk behavior is not riskier, but the community is riskier. Just to follow that up with a little bit more updated information. So again, this is still looking at this National Behavioral Surveillance System study. And so here, now we've got a bigger subset, and so they've looked at now over 8,000 individuals. 2.3% of them tested for positive for HIV infection. The prevalence was similar for men and women. HIV prevalence was 28% among blacks and 1.2% among Hispanics. Again, looking at some of the things that were different. Less than high school education, much higher prevalence than individuals who are high school educated or more. Household income, less than $10,000, much higher, almost more than double for individuals who had higher household incomes. Individuals who used crack cocaine in the last 12 months, much greater risk for individuals not using it. And then there was some difference between individuals living in the South and the Northeast in this particular prevalence study. Now, we're not so much in this talk talking about MSM, but I think that it's important to sort of think about the community and think about the relationships between black women and black MSM and understanding part of our community risk is understanding risk among black MSM. And so everything that I said about the black community with regard to high-risk environment with or without low-risk behavior is true for black MSM, only much, much more so. So this is just a number of studies that have shown, and I won't go through this in great detail, but it just shows that all the studies that have looked at sexual behavior among black MSM compared to white MSM actually show that they do not have more partners, are not more likely to engage in unprotected anal intercourse, but are much more likely to have sexually transmitted diseases, much more likely to live in poverty, much less likely to know about their HIV status, and much more likely to be HIV infected. And so, again, they didn't necessarily do their behavior and necessarily worse, but the risk that they encounter is much higher. As you all have heard, in some communities, as much as 46% of African-American MSM are HIV infected. And so if you are an African-American man who is having sex with other African-American men, then you really don't have any room for error. The condom can't break, you can't make a mistake, because the chance of you coming in contact with someone who's HIV infected is so high that you just can't take that risk. Now recognizing that in the black community, there is lots of interaction between black MSM or men who have sex with men but who don't necessarily identify as gay and black women. So given all of this, I've told you that the behaviors aren't necessarily riskier, that there's a lot that's going on in the community, but we have this difference in prevalence. So I believe part of what's driving the risk and what's driving the infection rate is that in this environment where there's a lot of infected individuals, quite a bit of risk, but you have a lot of individuals with low risk behavior. Folks don't perceive that they are at risk. So people don't think that they have HIV, that they're at risk for HIV disease. And part of that is our problem, was driven by our efforts from the early point of the disease. Those of you who have a few gray hairs remember that when HIV was first being described, when we were first warning the public, we talked about who was at risk for HIV disease. The folks who were at risk for HIV disease were men who had sex with men, people who were promiscuous, right? Well, what is promiscuous? Anybody that's having more sex than you, right? Folks who were injection drug users, and then there was something about Haiti in the beginning. And so there was this group of individuals that were defined as HIV, at risk for HIV. Now, if you are an African-American woman who only sleeps with men and who doesn't use drugs and who, maybe just has one partner or one or two partners in the last 10 years, you don't consider yourself to be at risk because that wasn't you. You consider yourself to be at low risk. And I think that a lot of that was driven by what we taught people. So now what we have to do is find a way to sort of teach it in a different way. Stop making it be about risk behavior and make it be about an environment and it doesn't require that you have to do something that's out of bounds, per se. You just have to be a part of a community that has a higher prevalence, which is basically the Black community. So I was interested in this question of risk perception, and so this was my belief that there was a low risk perception despite there being a lot of risk in the community. And so I worked with some folks in Chicago at the Core Center. So the Core Center is a very large HIV clinic that serves Cook County Hospital. And so the Core Center, we have about 6,000 HIV-infected individuals who receive care there. But what we also have is a large STD clinic that sees somewhere between 500 and 800 individuals each month with STD. So we have a lot of turnover, a lot of people that we see with STD. So we decided that in the month of August of 2010, we were going to do a survey to ask people in the STD clinic about their risk, about what their sexual behaviors were, how risky they thought their behaviors were, and did they think they were at risk for HIV. We also asked them a lot of questions about what they knew about HIV, and so we'll get to some of that. But this is who the population was. There were 500 individuals. 9 of them were excluded because they already ended up knowing that they had HIV. This was mostly a heterosexual population, and we categorized their risk based upon, whether or not they had a number of a different categories. So, a number of partners, whether or not they used condoms regularly, whether or not they use drugs with sex, whether or not they exchange sex for drugs. We took this population and we focused on the highest risk individuals. And so this is sort of describing who these individuals were. So they were overwhelmingly Black. They had very low income. So 45% of the population had a monthly household income of less than $500 a month. And so that's basically less than $6,000 a year. And you can see next up from there was individuals who were $500 to $2,000. And you can see, again, the overwhelming part of the population made under $20,000 a year. What were some of their behaviors? So this slide just breaks it down for the group as a whole, males and females, and sort of shows you the difference. So everybody was pretty much, a majority of the group was having vaginal sex. Again, I said this was primarily a heterosexual population. Lots of folks were also having oral sex. Notably, there was actually quite a bit of anal sex, even among the female population, which some folks found to be somewhat surprising. But let's check this part out here. Number of sexual partners within the last 30 days. On average, the men had 2. On average, the women had 1. No new sexual partners within the last 30 days. The women didn't have any. So this wasn't people who had a bunch of sexual partners. This was, again, women with 1 sexual partner. But when it came to inconsistent condom use, that was almost everybody, but again, 96% of the women inconsistent condom use. They weren't condoms. Now, condoms weren't a part of their repertoire. And that was for vaginal sex. It was also true for oral sex and also true for anal sex. Now, so in addition, we wanted to know about other sort of sexual risk type behaviors. So how often had they exchanged sex for drugs or for money or drugs? You could see that there was a good number of women, 15% of the women described that they had exchanged sex for money or drugs. There was a lot of alcohol use, as you could see, not really that different between the men and the women. Using drugs during sex wasn't that uncommon. Not a lot of drug use in this STD population, not a lot of needle sharing. But then look at this last part about jail. So 55% of the men had spent time in jail or prison, and 23% of the women. So again, bringing the environment and the risks other than their sexual activities, but exposures in other environments into the picture. And then having had STDs within the last year was a good portion. So these were people who were revisiting the STD clinic for the second time. They were not newbies. So then we also ask about some of the things in their environment. Like, what are some of the environmental issues? Do you have a sexual partner who's exchanged sex for drugs? Not that many of the women, but some of the men did. Do you have a partner who used drugs? Pretty common. A partner who had been in jail or prison? 40% of the women had partners who had been in jail or prison. So again, this is not just about their risk, this is about the environment and their partner's risk. And then having a sexual partner with STDs, at least a third of them, roughly a third of them had that. So then we asked them, now mind you, we narrowed this down to the folks who were the highest risk categories, who answered some of those risky questions, yes. And so this is just the highest risk among people in the STD clinic. Now, mind you, could argue that everybody in the STD clinic is somewhat high risk, but we even narrowed down further to say, who are the highest risk folks in the STD clinic? And we asked them, how much HIV risk do you think you have? And here's what they answered. So you can see that the whole group is in yellow, males are in red, and females are in pink. So no risk at all. This is the STD clinic. No risk at all was the majority. And so if you look here at the women, if you add these two up, so the people who had little or no, 82% of the women in that clinic thought that they had little or no risk for HIV. So somehow, now mind you, the other thing that we asked them, and I didn't put the slide in just for the sake of time, but we asked them a whole series of questions about how you get HIV, and 90+% of folks got all the questions correct. So it wasn't that people didn't know how you get HIV. There was this disconnect between what they did, what their environment was, what their partner did, and their risk. So somehow there's this wall between recognizing HIV and recognizing personal risk. And so we also, now this was done in 2010, mind you, so this was even before the first IPREX data that showed us that PrEP could be effective was published, but we were curious about whether or not people might be interested in PrEP, and so we basically said, hey, if there was a pill that you could take that might decrease your risk for HIV, would you be interested in taking it? And interestingly, a large proportion of them said yes. However, when we asked them how they wanted to take it, once a day was the least popular. Most people wanted to be able to take it right before sex or the day of sex or once a week or something like that, which tells you a lot about sort of where, if we're going to talk about using effective PrEP, we better find a different way to do it, right? Make it be able to be right before sex, or certainly the everyday part is challenging. So then we asked them, if you weren't interested, so we looked at the ones who said they weren't interested in taking PrEP, and we asked them why. And the most common answer was, I practice safe sex already. I just let that sink in for a minute. So, and then again, the next one of the high risks was that I have no risk. So, you know, again, this sort of disconnect between recognizing perception of risk, people not thinking that they were at risk. And then when we did an analysis sort of looking at some of the factors associated with who were the people who were the least likely to be, interested in PrEP, the folks with the lowest educations, people who had some high school or less, seemed to stand out as the ones who were the least interested. And maybe that's from not clearly understanding exactly what the benefits might be. I'm not clear exactly why that is. Now, some of the unpublished data that I'm going to quickly share a little bit with you was that in addition to doing this survey at the STD clinic, we also went to Black Gay Pride in Chicago. Now, I don't know, is there a Black Gay Pride here in the Raleigh area? Some people are nodding. Black Gay Pride. It's just Gay Pride. So most people are just saying this. So in Chicago, there is a specific, I mean, it's a big city, and so there's a specific weekend that is Black Gay Pride events. And so we went to that event, and we interviewed people. Basically, we surveyed people with the same survey for the STD population. And so this is some of that data. And so if you just focus here on the Gay Pride group here. So we had basically about 200 folks that we looked at. And there's just a few points that I wanted to make because I think that this just illustrates a couple of other additional things. So a few things were different between the group. The Gay Pride group, again, this was Black Gay Pride, was a little bit more Black than the other group. The education level was a little bit higher at the Black Gay Pride event. Incomes were a little bit higher at the Black Gay Pride event. As you can see here, you had a lot more homosexual individuals, more marijuana use, but less of some of the other drugs, less drug use, less jail use, less time having, less likelihood of having been in jail, lower risk of STDs. But then, again, looking at the risk. So here we found, because again, this wasn't someone who was coming into an environment where we clearly knew they had risk, but we knew this was a group that might be at risk. And so again, we categorized them. And so 67% of the folks at the Gay Pride event were what we categorized into high risk. And so you can, here, this just gives you an idea about the answers to the statements. So again, we asked them how much they knew. So you get all these questions. You can get HIV through vaginal sex, anal sex, oral sex. The oral sex one was interesting in how much it dropped down, but that's something that we're not that surprised about. But you can see multiple partners increases your risk. Most of these folks got these questions right pretty much most of the time. And then this tells you a little bit about some of the risks of this group, but I mostly wanted to get you to this point, which was sort of the same question for folks at the Gay Pride event. And here, again, very high numbers of individuals who thought they had little or no risk. And so, it's not just folks in an STD clinic. It's not just heterosexuals. It is sort of this disconnect, even in populations that know that there's a high. Now, remember, this is Black Gay Pride, and I talked to you about all that prevalence in the Black MSM community, but there was no connection, even though use of condoms on that last slide was extremely low. And then we asked them also about whether or not they were interested in PrEP. And interestingly, the Gay Pride group had lower interest in PrEP than the STD clinic group. I won't go through this too much because, again, it just reiterates some of the points that I already made. But I wanted to talk about another study that was very similar to ours, but actually even larger than ours, and asked some of the same questions. And so here, this was a study that was done in Philadelphia, and so they have a rapid HIV testing program. And so in this program, they basically just decided they were going to survey a bunch of folks about their behaviors, and then about their perception of HIV risk. And so you can see who the population was. It was mostly African American again. There's a good amount of drug use here. You can see a little bit more in the men, about 20% of the men, only about 14% of the women, quite a bit of marijuana use. Alcohol use was fairly high in both groups. Trading sex for drugs, 10% of the women had traded sex for drugs or money. Again, sex as a commodity being a big part. Condom use always was 10%. Never was 30%, around 30% for the group as a whole, but again, looking here specifically at the women, 37% of the women never used condoms. The sometimes and never should probably be lumped together because that's probably about equivalent. And so you can see not a lot of condom use. Having had a previous STD, there was quite a few individuals who did. Number of sexual partners. Now, they used a number that was much higher than the number that we used. We just looked at the overall list. They said less than 5 in the last months or greater than 5. But you can see the majority of them, particularly the women, 86% of them were less than 5. I probably would have used, if I'd done this, I would have used a lower number because I think you probably could have said less than 2, like a number of other studies have shown, and shown a similar number. And then this was mostly a heterosexual population. And so then they looked at their HIV testing, whether or not they'd ever been tested, and a lot of them had a previous test. It turned out that they tested everybody in this population, and you can see the number here, that there were 1.3% of the men and 0.9 or almost 1% of the women were HIV positive. So again, that's a high number, so a high number of individuals. But then when you ask them about their risk, so this is self-reported perceived HIV risk. None, pretty high, about a third of the group. Low, so if you put none and low together, again, you got about 80%, very similar to our number, about 80% of folks in this population with about 1% prevalence didn't perceive themselves as being at risk. Now, the medical assistants who actually were asked then how much, they also were asked how much they thought there was a risk. And there was also some misunderstanding among them, you might argue, because they also saw low or no risk among a lot of the individuals, although they saw high risk in about double of the people who perceived themselves as high risk. So again, low perception of risk, and I forgot about the build. So then, why you say, well, why are you talking all this stuff about risk? What does it make a difference whether or not they recognize they're at risk? Well, I would argue that how much risk you think you're at affects your behavior. If you don't think you're at risk for HIV, you think it's okay to not use a condom. If you don't think you're at risk for HIV, why would you be interested in taking a pill every day to prevent your HIV risk? Because you're not at risk. And so there are a couple of studies that I think kind of illustrate that, and you'll let me know whether or not you agree with me. So some of this is data you guys are already familiar with. These are some of the PrEP studies. So the first one I'm going to show you is the Partners PrEP study. So this was a study that was done primarily outside of the U.S. and in sub-Saharan Africa, and they took a large number of HIV negative partners in serodiscordant heterosexual couples. So the negative partner, and you had a couple, one negative partner, one positive partner. And so these individuals are randomized to receive oral tenofovir plus emtricitabine, or placebo. And they found in this study that both PrEP strategies were associated with a significant reduction in HIV transmission compared to placebo. And so the efficacy of taking PrEP in this study was 71% for women, 63% for men, and then the combination was similar, very effective. Now, there's another study that you all probably maybe heard a little bit about, which is the FemPrep study. So FemPrep was a study that looked at women who weren't in couples. It was just looking at women who were perceived as being at risk for HIV because of being in an environment with high prevalence. And so they asked, these women did a similar study, basically, where they were given PrEP. And this study didn't get presented in as much detail, but it was estimated that 97% of the pills were taken based upon the pill counts that these women gave. However, when they looked at plasma levels for these women, they didn't find it. So women didn't take their medicine. Now, mind you, these women, the women on the top in the study clearly above, your partner has HIV. You recognize you're at risk because you know your partner has HIV. The lower study was women in the general environment. And they were, you know, it was about, well, he doesn't look bad, so he probably doesn't have HIV. And then to follow this up in more detail, we heard just this year the very important voice study that really was designed to sort of definitively answer this question about PrEP in women. And so this was a study of 5,000 women done mostly in South Africa, and they were randomized to several different possibilities. They were randomized to either getting a vaginal gel, so vaginal gel, tenofovir vaginal gel versus placebo, or tablet, and then they could either have gotten the combination, you know, tenofovir FTC, tenofovir alone, or the placebo tablet. Okay, so 5 different potential things they could have gotten. And so here's what happened. So here are the number of infections for folks based upon what they got. The folks who got the combination tenofovir FTC, 61 infections versus placebo, 60 infections. Tenofovir, 52 infections versus placebo, 35 infections. 61 and 70. So you can look across this, and it's not very hard to see that it did not work. Well, it didn't work not because we haven't proven whether or not PrEP works in women. What we've proven is that these women didn't take it. So adherence was low across all the groups. Drug was detected in only 29% of the blood samples when women in the combination tenofovir FTC group, 28% of the blood samples in those in the tenofovir group, and 23% of those in the gel group. Meanwhile, the patients said that they were taking the drug 90% of the time. And so in my mind, this is an illustration of perception of sort of the outcome of perception of risk. If you know that that risk is right in front of you, then it's one thing. My behavior can be one thing. My behavior will be one thing. I'll take my drugs. I'll use my condom. If I don't recognize my risk, I think that there's a theoretical risk out there, then it affects my behavior. And in this study, I'm not taking my meds. And so the last study that I'll show you is a little bit different, and that this was, I'm sorry if it's hard for you to read, I'll kind of take you through it. This was presented at last year's International AIDS meeting in Washington, presented by a group out of Boston, and they basically did a focus group. And so they took 26 English-speaking black women, and they were recruited from an inner-city health center, so just a regular old health center that was sort of a safety net health center. And they basically did a focus group with them where they talked about their perception of risk of HIV. They talked to them, they gave them a description of PrEP, and then they asked them about PrEP acceptability. And so here's a little bit of the information. I'm not showing you everything from it, but I wanted to show you a couple of parts that I thought were important here. So a few points that they wanted to make. Monogamous women tended to consider themselves to be at low risk despite their partner's behaviors, including infidelity. So their risk perception was that 52% of them said that they were not at risk at all, and then 24% of them thought that they were at risk. Here was a quote from one of the women. "I was with one guy for many years. He was a cheater. I wasn't. And still, we did not get AIDS tested before we were together." You don't even think about it. You don't think about, you just don't think about it. You just say, that's who I'm with. So you just kind of accept his risk and not necessarily worry about it. There was limited awareness of HIV incidence in the black community. And knowing an HIV-infected individual didn't alter their personal risk perception, but was associated with an increased interest in learning about HIV. Knowing about an HIV-infected person, or knowing about one, relating to one. A couple other points from this study. Perceptions of prevention strategies. This quote is pretty interesting. It said, "I don't put 100% in the condoms because they are not always effective. But it is what it is, because that's all we have, and you use what you have." And then when asked sort of, what would you do? She said, "What would I invent? An instant test You use before you do anything. So maybe we just need to have everybody have those little things, give them out, and so that you can just test folks right at that moment. So perceptions about prevention strategies. So they were concerned about condom failures. They perceived the need for new prevention strategies. They expressed a desire for prevention strategies that would alert them to their their partner's HIV status. So they wanted to be able to know what their partner's status was without having to march down to the health department together and get tested. And then PrEP interest, the majority of women were interested in PrEP. They liked the pill better than a gel. They thought that it was more private. They didn't like the inconvenience of a gel. They were concerned about vaginal side effects and leakage related to a gel. Now, interestingly, there was a study that compared U.S. women and South African women, and they were exactly the opposite with regard to their interests. U.S. women were much more interested in taking a pill for PrEP, whereas South African women were much more interested in taking a vaginal gel for PrEP. Why that is, I don't know. But so we've got those two studies that look at PrEP in women in high-risk environments. In developing countries, we don't really have a good PrEP study that's been done to understand interest in PrEP and sort of implementation of PrEP in a domestic environment, and that's something that we're actually trying to address. And then talking about adherence, women who had taken pills previously were amenable to taking a daily drug, but they said that they prefer to just take it episodically or after sex. And just to give you a couple more of the quotes, it says here, with a pill, he says, "What's that, baby?" You can say it's a vitamin. You could always get away with taking a pill, but you could always say that it was birth control. And then the other quote was, "When I was out there using, I didn't have a condom. I didn't have one." But basically that she still had sex. But if I had it, I would use it. I still took my psych meds, though. So what can we do better? What can we do better? I think that if we are going to do something to address this question of perception of risk, it's not just a question of knowing. It means that people know how you get HIV, but I do think people need to have a better understanding of the community risk, the prevalence in the community, and that it doesn't, all it takes is sort of the one-time kind of thing. And so there needs to be much more awareness in the community, and that to me is about really getting information out in the media. I do think that there should be a, HIV-infected regular person on, for example, Atlanta Housewives, right? Something that basically makes this someone who you recognize, who you live with all the time, who you see as a part of your community, and understand that she got HIV from her husband or her ex-husband or her boyfriend, because I take care of a ton of women, and the overwhelming majority of those women acquired HIV from their long-term boyfriends or their husbands. They were not ever sex workers or any of the misperceptions of what women who are living with HIV are. Women, the part of that disconnect is that it's easy to be able to say, well, they did something different than what I'm doing. And the reality is that that's not the case. And so I do think that we can make that story a more widely recognized story. And then part of that increasing media would also decrease stigma. Again, if we recognize how much HIV exists in our community, how many people that we interact with every day are living with HIV, then it would help to diminish the stigma, I believe. This is the book that's been in my head for many years. It basically tells real-life stories of women with HIV disease, because every woman who comes to my clinic has a really interesting and fantastic story that I would like to be told, because I think that it would be educational for other women. And again, back to this risk perception thing, when I see women who are newly diagnosed in my clinic, for the most part, they are stunned and shocked by their diagnosis. They did not expect it. When I see men or MSM in my community, they kind of knew they were at risk, and they're not that surprised. Some of them were getting tested every 6 months because they knew that they were having risky behavior. It's a completely different group and a completely different experience, which again, when we go back to the cascade discussion we were talking about, those same group of women who didn't think they were at risk are the same group of women who will go back and get HIV tested 3 and 4 and 5 times before they will really accept that they're positive. And those are the women who are often lost and don't come back to clinic right away. So what else can we do? Empowerment, I think that, we talked about some of these challenges for women. There's a really, I think, neat Greater Than AIDS program from the Black AIDS Institute. It's called Empowered. People probably recognize the greater than sign from the Black AIDS Institute, the greater than AIDS symbol. Well, now they're using it for Empowered. They've got Alicia Keys out there leading the charge. I think that having, if we could have more HIV-infected women out there talking about their lives and talking about how they've dealt with their HIV and challenging the myths, as well as just making young women more empowered about being able to demand condom use and demand prevention for themselves, I think was critically important. Women-controlled prevention methods. PrEP may be one of them, but we have to talk a lot more about that. Of course, treatment as prevention is a big part. If we can have more people that are on treatment that aren't transmitting their virus to individuals, that's much better. I mentioned PrEP, but we've got to make it more acceptable for women, and putting it associated with coitus would be a big move in the right direction. I also think that we can maybe sneak it in if we can attach it to birth control. So again, the concepts that are currently in development about making a combination vaginal ring or diaphragm that both can protect against becoming pregnant as well as protect against HIV risk, so that women can get both because they're trying not to get pregnant, I think would make a big move in the right direction. And that's my last slide. I certainly could thank a whole lot of people who contributed to this, but I'll stop there. Thank you. Okay. Any questions out there?
What other ideas do you have? Give us some. Maybe other people in the room have.
Well, I'd certainly be open to the ideas that people have in the room, but yeah, I do think we need to start younger. And again, part of this is having people recognize that it doesn't require that he be something special. So, some women have the misperception that he has to be someone who is on the quote-unquote down low, this notion of men who are bisexual. All of the myths that are out there about who puts you at risk, we have to start challenging those early on. So it should be that any guy that you interact with could be HIV infected, and so if we start empowering them early on and we know that they're starting to have sex early on, that we have to start talking to them about HIV risk early on. It could be any guy. It doesn't require that he's something special. So I think changing the message that there's this certain group of guys that you have to worry about, as opposed to this anybody, that we need to start that from the beginning. I have no idea about Scandinavia. I know there are no black people in Scandinavia. but with regard to what kind of programs they have and why there's so little HIV risk, I couldn't even begin. I couldn't even begin to tell you.
Well, it happens to everybody.
Right, but I also would say that Denmark is also one of the places that hasn't shown any difference by different ethnicities as far as outcomes. And other places with universal health care, like Canada, on the other hand, even though there's universal health care, they have the same disparities. So universal, I'm not disagreeing with you. I'm just saying that universal health care is not the utopia that will fix this problem. Because the reality is that, we recognize that universal health care in Canada, yes, everybody has access to health care, but they don't have access to the same health care. And that's going to be the case, as we know, with the ACA. More people are going to have access to health care, but they're not going to have access to the same health care across the board. And so, unless you really do that, that, you're not going to sort of fix those disparities. And all of those other disparities around healthcare, which means the STDs, which all the poverty stuff, though, as long as those exist, there's going to be the disparity in HIV. And I think the other, just one quick, so a little bit off the topic point, though, about so the HAART era and the changes in the HAART era, the assumption would be that the disparities in HIV outcomes would have improved in the HAART era. That would be what we would hope. Everybody, you know, everybody's doing better. But in reality, the gaps have actually gotten wider, because now you took a disease that everybody got sick and the overwhelming majority of people died from, and now made it so that people that aren't in care or that can't consistently stay in care or don't have access to care die, whereas opposed to the best health care don't. So the gap is now widened. And so all of the things we talked about with the cascade, all of those differences are wider by race. And so, but that's a little bit off topic, and we can maybe talk about that a little bit more, and I'm sure I'm over time. So thank you so much.